ലൈവ് ആണല്ലോ.
അല്ല, യൂട്യൂബിലോട്ട് ലൈവ് ഓടണം.
ആ ലൈവ് എടുത്ത് നോക്കിയോ. നമ്മൾ 3 പേരല്ലേ ഉള്ളൂ ഇപ്പൊ, വേറെ ആരും ചേർന്നിട്ടില്ലല്ലോ.
വേറെ ആരും ഇല്ല.
ലിങ്ക് കൊടുത്തില്ലല്ലോ.
ലിങ്ക് ആർക്കും കൊടുത്തിട്ടില്ല, നമുക്ക് മാത്രമേ ഉള്ളൂ.
എന്നാ കൊടുത്തോ. അങ്ങനെയല്ല,
സൂരജ് നിന്റെ ഇത് മ്യൂട്ടാ.
ഡോക്ടറിനെ ഞാൻ വാട്സാപ്പിൽ ഇപ്പൊ ലിങ്ക് അയച്ചിട്ടുണ്ട്, യൂട്യൂബിന്റെ.
ഓക്കെ. ദേ ബോബി ഇരിക്കുന്നു, ഞാനുണ്ടല്ലോ. പറഞ്ഞ സൂരജ് ഒന്നൂടെ.
ഡോക്ടർ
ക്ലിയർ അല്ലേ?
ക്ലിയറാ, കുഴപ്പമില്ല.
ക്ലാരിറ്റി കുഴപ്പമില്ല. ഒരു ലാഗ് ഉണ്ടെന്നുള്ളു, വേറെ കുഴപ്പമൊന്നുമില്ല.
ലാഗ് ഉണ്ട്,
ഒരു 20-30 സെക്കൻഡ് ലാഗ് ഉണ്ട്, അത്രേ ഉള്ളൂ. ഡോക്ടർ ഇത് മ്യൂട്ട് ചെയ്ത് വെച്ചോ, മറ്റേ മൊബൈലില് യൂട്യൂബ് വെച്ചേക്കുന്ന, അല്ലെങ്കിൽ ഭയങ്കര ഇന്റർഫിയറൻസ് ആയിരിക്കും.
മ്യൂട്ട് ചെയ്ത് വെച്ചോളാം. പക്ഷെ ഇതില് വേറെ പ്രശ്നമുണ്ട്. എനിക്കിപ്പോ ഇതില് മറ്റേ കമന്റ്സ് ഒന്നും കാണുന്നില്ല.
കമന്റ്സ് നമ്മളൊന്നും ഇട്ടിട്ടില്ലല്ലോ. ബോബി ഒരു കമന്റ് ഇടാവോ?
ഞാൻ ഇടാം. അതിപ്പോ കമന്റ് ചെയ്യാനുള്ള ഓപ്ഷൻ അല്ലേ?
ഹലോ എന്ന് പറഞ്ഞാൽ മതി.
ഡോക്ടർ ഞാൻ അയച്ചിട്ടുണ്ട് ഒരു കമന്റ്, കാണുന്നുണ്ടോ?
ഡെസ്ക്ടോപ്പിൽ എനിക്ക് കമന്റ് ചെയ്യാനുള്ള ഓപ്ഷൻ കാണുന്നില്ലല്ലോ.
ഹായ് വെൽക്കം എന്നൊരു കമന്റ് ഉണ്ട്.
ഞാൻ ഇട്ടതാ.
ബോബി
എനിക്ക് ഇതിനകത്ത് കമന്റ് ചെയ്യാനുള്ള ഒരു ഓപ്ഷൻ ഉണ്ടോ ഡോക്ടർ? സൈഡിലാണ്. ഓക്കെ,
ഞാനിങ്ങനെ പറഞ്ഞാൽ പോരെ. യു ക്യാൻ ലീവ് യുവർ കമന്റ്, യു ക്യാൻ ലീവ് യുവർ ഡൗട്ട്സ് ഓൺ ദി കമന്റ് ബോക്സ്.
മതി.
മോസ്റ്റ് ഓഫ് ദം മൊബൈൽ ആയിരിക്കുമല്ലോ യൂസ് ചെയ്യുന്നത്. മൊബൈലിൽ ഡെസ്ക്ടോപ്പിൽ മാത്രമേ റൈറ്റ് സൈഡിൽ കാണുന്നുള്ളൂ, മൊബൈലിൽ താഴെ തന്നെ.
ബോബിയുടെ ഇത് കണ്ടു, സൂരജിന്റെ കണ്ടു, ഇതെല്ലാം കാണാൻ കമന്റ്സ് എല്ലാം വരുന്നുണ്ട്, ഒരു കുഴപ്പമില്ല.
ഒരു ലാഗ് ഉണ്ടാവുന്നില്ല ഡോക്ടർ. എന്തായാലും ഡോക്ടർ സെഷൻ കഴിയുമ്പോഴാണല്ലോ ഇത് ചെയ്യാൻ പറയുന്നത്. അപ്പൊ ഒരു 30 സെക്കൻഡ് ലാഗ് ഉണ്ടാവുന്നുള്ളൂ. നമുക്കൊരു
ഞാൻ കണ്ടു, അതിപ്പോ ഞാൻ കാണുന്നുണ്ട്, കയ്യിലുണ്ട്, എടുപ്പുണ്ട്. അല്ല അത് കുഴപ്പമില്ല, ലാഗ് വന്നോട്ടെ, കുഴപ്പമില്ല. കാര്യം ക്ലിയർ ആവുന്നുണ്ടല്ലോ ഇതില്.
അതെ അതെ
ക്ലിയറാ.
ഡോക്ടർ എന്തായാലും ഡോക്ടർ സെഷൻ കഴിയുമ്പോഴാണല്ലോ ഇത് ചെയ്യാൻ പറയുന്നത്. ഒരു 30 സെക്കൻഡ് ലാഗ് ഉണ്ടാവുന്നുള്ളൂ. അത്രയും സമയത്തെ ഒരു ലാഗ് ഉണ്ട്.
അല്ല കാര്യം ക്ലിയർ ആവുന്നുണ്ടല്ലോ, മതി, കുഴപ്പമൊന്നുമില്ല.
അപ്പൊ ഡോക്ടർ നമുക്കൊരു കറക്റ്റ് 4 തന്നെ പിടിക്കാലോ അല്ലെ?
കറക്റ്റ് 4 വിളിക്കാം. അപ്പൊ അങ്ങനെയാണെങ്കിൽ ഇപ്പഴേ ഇതിട്ട്
ലിങ്ക് ഷെയർ ചെയ്യാണ്.
ലിങ്ക് ഷെയർ ചെയ്തിട്ട് നീ ലൈവ് മറ്റേ നമ്മുടെ ഇത് കൊടുത്തിട്ടാ മതി.
ഞാനിപ്പോ വാട്സ്ആപ്പ് ഗ്രൂപ്പില് വി ആർ ഓൺലൈൻ, യു ഓൾ ക്യാൻ ജോയിൻ ആസ് സൂൺ ആസ് പോസിബിൾ ആൻഡ് ലെറ്റ്സ് നോട്ട് ഡിലേ ദ സെഷൻ എന്ന് പറഞ്ഞിട്ട് മെസ്സേജ് കൂടി ഇട്ടേക്കാം.
ആയിക്കോട്ടെ ഡോക്ടർ, കിട്ടോ? ഞാൻ ലിങ്ക് ഇപ്പൊ തന്നെ വിട്ടേക്കാം.
ഡോക്ടറെ വീഡിയോ ക്ലോസ് ചെയ്തോ ഡോക്ടറെ. ഇപ്പൊ ലൈവ് യൂട്യൂബിലോട്ട് പോവില്ല, അവരാരെങ്കിലും കയറി വരുന്ന.
സൂരജ് അത് ഇതിലിട്, സ്ലൈഡ് പ്ലേ ചെയ്യും. സൂരജ്
ഡോക്ടർ
പ്ലേ സ്ലൈഡ് പ്ലേ.
കേട്ടില്ല.
സ്ലൈഡേ പ്ലേ ചെയ്യാനായിട്ട് മറ്റേ ഇതിലിടാതെ. അത് തന്നെ
വന്നില്ലേ? അത്
ഇതുവരെ വന്നില്ല. യെസ്, ഇപ്പൊ ലൈവിലാണല്ലോ അല്ലേ?
അതെ.
അപ്പം തുടങ്ങാറാകുമ്പോ എന്നോട് പറഞ്ഞാൽ മതി.
ശരി. A warm good evening to everybody. Today we have a meeting, and the topic today is management of open apex with MTA. Today our speaker is Dr. Shibu Sridhar, and he's already online, and we'll just start the meeting in another couple of minutes. Dr. Shibu, over to you. Please go ahead, and everybody have a great time.
Thank you, Suraj and Modesta, for the invite. Now let me try to start it up. Suraj, can you tell me whether everything is right? Am I audible?
Yes, doctor, you are audible. We'll go ahead.
All fine, right?
Yes.
So, good afternoon, my dear friends. I'm Dr. Shibu Sridhar. I'm an endodontist and restorative dentist practicing in Cochin. And now, today, the topic is management of open apex with mineral trioxide aggregate or MT. So, first of all, let me extend my regards to Team Modesta and Suraj for organizing this session. This is, I feel, almost the ninth session which has been organized by Suraj on various topics. Hats off to you, Suraj. One thing which I want to tell you all is, see, myself, I'm a practitioner. I'm a clinical practitioner, and this lecture, which is extending for about 1 hour, is mainly focusing on the clinical aspects of management of open epices. So I will be focusing more on the clinical side. If somebody is interested on the other aspects of MTA, then it's like you can always message me, you can always text me. I would give my number. You can always contact me, and that is how we can manage such a vast topic in so much of limited time. So let's start. So what you see here, the first picture, what you see on the slide is the open apex case. Now, the main issue is how are we going to manage such a case? So when we are dealing with endodontics, we have two major concerns: to obtain a good apical seal and to obtain a good coronal seal. So let's consider an open apex. See, I am trying to be as simple as possible. There are many more implications. We are not talking about how the open apex happened. All these things you can refer to your textbooks. Even you can Google up. So it gives you enough and more information on the open apices. So we are dealing just with the management. The first figure, what you see here, is a closed, it's a bottle. So similar is an endodontic case where you have the apex, which is now we have a different situation. We have a situation wherein the apex is open. So we have to take care of some issues, which we will see. What all are those issues we will see in the slides to come. So before that, one of the, I'm not a brand specific person, But I always prefer bio MTA for my cases. I'm not a person who's too much into biodentin. I don't have anything against biodentin, but I prefer MTA more. Fine. The reasons. I mean, it's like if you have any concerns regarding that, you can well text within the comment box. I would be replying that to you. It's a big story. So let's see. We are directly heading on to the topic. So let's see how we manage open up ISIS with bioMT. So now we have seen the initial things, initial preparations. So before starting with management of an open apex, the first thing we would do is mix MTA. See, normally a 3:1 ratio is the most appropriate ratio in managing the powder and liquid. Uh, One thing I have to add up to this is when you see the speakers, or when you follow the speakers from abroad, they would be mixing almost 0.14 grams of MT with 2 to 3 drops of liquid, which is nothing but deionized water. But that is not possible for us from the Indian practice point of view, because they empty all the contents from a small compule and they mix it completely. So considering the cost of the material, we might not do that. So we'll explain that in the coming slides. So this is half. The first slide is half you manage with BioMT. One of the biggest advantages with BioMT I have found is it's very easy to handle. It's the consistency after the mix is just like your addition silicon putty material, the addition silicon putty material. So that, I mean, even taking it out, placing inside the canal, packing everything is a much more simple effort. So let's leave BioMTA there. Then it is like we have to think of the systems which enable us to pack the mixed material at the apex. So we have different systems available, and one of the most prominent being the MAP, micro apical placement system. So you would find this on Google, YouTube videos, how to use all these things. You have 0.9, 1.1, and 1.3 sizes available, which would help you to meet almost all the cases coming up to you clinically. So this is a system wherein it helps easy application of MTA into the apical region. Now, let's leave all these things aside. Fine. I'll show you a case where how I manage a case. So let's see it. This is an extracted tooth, and I have tried my best to simulate a natural situation. This is an extractor tube. This was having a closed apex, and I have done in such a way that I made the apex open. If you see, the coronal diameter is actually smaller than the apical diameter. So almost like an open apex case, I've made it. Now we'll see how clinically I manage a situation. So that's it. You can see the open apex. Now I would take a plugger. In fact, the bigot plugger, which would go at least 2 mm short of my working length. You can see my plugger is going 2 mm short of my working length. Then I'm going to mix MTA. The consistency of an MTA mix should be like a moist sand. It is not like a GIC or not like a cements. The particle size is bigger. So you will feel it like moist sand. You should be feeling it like moist sand, which enables you to take it on a micro applicator tip. Like what you see over here. I pack it into the orifice, push it down, take a plugger, take it to the length which was pre-specified. You can see this is through my microscope I have recorded. You can see I'm packing it apically. So this is the radiograph. Now you have to expose a radiograph to see how your apical packing is. So apical 4 to 5 millimeter I have packed with MTA. So that is what the statistics say, the studies say. When you have about 4 to 5 millimeter of MTA at the apex, you get the best possible seal. Now I take my backfill gun and then just extrude warm gutta percha into the canal. And you can see the sealer, which is lightly coated on the slab, on the sides, on the walls of the canals, being coming from all the 4 directions. I'll take a bigger plugger now and I'll start condensing it circumferentially with an apical force nicely to pack it inside the canal system, and that's a final radiograph. So I have a good apical closure with MTA, and the remaining I have completed with warm vertical compaction, and the coronal part I would be filling with any composite resin. So this is the workflow with MTA. Now, let's go further. See, I was telling you from the very beginning, I'm a clinician. For me, the most important thing is managing a case which comes to me. Fine? So all my webinars, all my sessions on endodontics as well as restorative dentistry is always oriented on clinical management. Fine. So let's, and that is one of the most effective way of communicating. See, I would go too boring if I am going to sit with the constituents of MTA, what it is made up of, what is the powder constituents, what is the liquid, all these things. If I'm sitting with, I would consume all the time talking about the material, and I would not impart anything to you during this time, very limited time. So now let's see a clinical case. And let me tell you first thing, I have tried to incorporate as much as cases as possible so that I can communicate to you the various possibilities wherein you can use mineral trioxide aggregate or MT. So here is a case of an open apex. You can see the coronal diameter is very small and I have a blunderbuss apex. Fine. The tooth was non-vital. It was discolored. That is why the patient came to me. So the first thing we have to see in the X-ray is the canal is wider apically than the coronal diameter, which is not the case of a usual root canal treatment case. We have smaller apical diameters and wider coronal diameters. In open apex cases, we have smaller coronal diameters and larger apical diameters. Another thing to notice is we have very thin dentinal walls. So if somebody asks me, what is the rotary I have to use in such a case? Fine, since we have movement, we all have movement, we all have taken a step exclusively into rotary endodontics. This is one question which I find most of the time. Which is the best suited rotary instrument in managing a blunderbuss canal or an open apex case? So let me ask you a question. It's simple common sense. Do any type of instrument has a role in such a case? Absolutely no. We all know that. We're not supposed to remove any dentin from the already thin existing dentin. Fine. So it's not the instruments which is having a bigger role. It's just the irrigants which are having a greater role in open apex cases. Fine. Uh, I'm leaving a catch for you here, the irrigants. I'll come on to that later. So let's see the biological consequences here. The tooth is non-vital. We have an immature or an open apex. The apical diameter is wider and the coronal diameter is lesser. And it's like an open bottle, a bottle with the bottom part being sliced off. So you don't have a barrier to stop the obturating material at a particular level. So here, if you see, I cannot stop my obturating material here. It can get pushed off. If I exert pressure, obturating material can get pushed off. So our aim is to get a good apical seal with some sort of a suitable material here. And then, if our obturation strategies are not up to the mark, we would leave a big room for apical leakage and subsequent failure. When we were doing, when I was doing, I would put it in that way. When I was doing my post graduation, uh, we used to manage all these cases with customized GP con technique uh, with the apex of the cone dipped in some sort of a solvent like chloroform or eucalyptus oil, and then we used to take an impression of the apical part and then cut off what was existing outside. We could make out the apical ruggedness and cut off whatever is beyond that ruggedness, use it as a master cone, and then do the obturation. So all these things eventually ended up with more amount of failure rates. So we were forced to uh, come up with something which was most promising, which gave much more consistent results to the patient. And then came MTA. And there I started a good bond with this material, MT. So I started MTA some almost 15, 16 years back, and still I stick on to MTA because I find it a great material. I have never associated MTA with higher number of failures. That is, if you fill it properly, it stays there, the patient is fine, the tooth is fine, it serves very well for years together. And that is one reason I am still an MTA fan, maybe for the last 13, 14 years. So let me establish that dentinal walls are more susceptible to fracture during and after the treatment. So the first thing in such a case I would do is I would take a plugger. We should have a good set of pluggers. So I take a plugger, then mark the working length of the plugger to 2 mm, 2 to 3 mm short of the working length. Fine. Then I take a bolus of MTA, which is 2 to 3 mm. I will place it inside the canal and push my plugger to the pre-established working length. My working length is 3 mm short of the apex. You can see on the radiograph. So that I deposit a bolus of MTA or an aliquot of MTA, which is 2 to 3 mm in thickness at the apical part. I'll wait for 2 minutes. That is, 1 minute will go in my mixing, 1 minute will go in my placing it to that portion. Then I wait for 2 minutes. Almost 4 to 5 minutes is the sitting time. At 4 minutes, almost it is partially set, so that I can give a bit pressure onto the small aliquot of MTA which I've placed at the apex. I nicely compact it circumferentially with a plugger. Of course, magnification is very important. A microscope makes all these things, an operating microscope, dental operating microscope makes all these things very easy. So I place my apical barrier intact, which is almost 3 mm. I will place one more increment. I'll compact it nicely. And then I can go ahead with backfilling. We'll go to the next radiograph. So you can see I've taken a radiograph, I have exposed a radiograph. You can see I've packed the apical MTA, and then I went ahead packing almost more than 6-7 millimeters with MT. So you can see here, this much is my MTA. Almost I can say 7 millimeter is my MTA. The idea behind this is I would love to give some material which can reinforce the root structure. We all know that the shear strength of of MTA is up to 70 MPa. The shear strength of MPa is up to 70 megapascal. So which would enable the tooth to be reinforced to that much level. Rest of the portion I have filled with Garaperka, maybe 3 millimeters. You can see the clinical picture here. And then I go ahead with the orifice filling. So that was one classic open apex case which I demonstrated to you. See, we do a management of an open apex with different perspectives in our mind. The first case was very simple. That was a case, I mean, wherein it's like I've given veneers on both the central incisors, and it's been well in service for almost 7 years now. I have a good follow-up of the case, and normally I show the case in my uh, indirect restoration webinars. So here it's a different topic. So I'm not going into the aesthetic side of all those things. I'm just going on to the root canal treatment side of these things. So here is a very different case. So this is a very young boy who came to me with severe pain on the tooth. The history they conveyed to me was a bit interesting. He had a fall. This central incisor was intruded completely. Then they went to a dentist who told them, keep it like that, we'll see what is going to happen. Then it came out. But they didn't realize it came out because of the pressure which was developing due to the creation of a cyst, periapically. It came out due to the cystic pressure. So, in such a case, what is my aim? So, he was near to 9 years or 10 years when he came to me. So, my aim is to retain the tooth to the maximum. I know it is going to fail at some point of time, but let me see how much I can retain it. Why? Because I don't have any bone here. If I get some bone later, when he steps into his adulthood, I could extract this tooth and give an implant. So I would term these cases as pre-implant therapies. So it was like I just opened up the flap. There was no buccal bone existing. The tooth was too mobile in the socket. I just removed it, placed it in saline. The cyst was enucleated. Placed the tooth back, splinted it nicely. Then a graft was given and I closed it up. And this is after almost 3 years. This picture is after 3 years. And you won't believe, now it is almost 11 years after the procedure. There was good amount of bone. I wanted to give an implant on this case, but the tooth is still existing. I recently did a lot of treatment for his mother, but still, since the tooth is existing in his mouth, since he is not having any symptoms, we have also kept quiet. Nothing wrong in that. Let's see how long it goes. So this is one big advantage of the material. Something which was hopeless. We have done the treatment. We have retained the tooth. It's existing in the mouth for 8 to 9 years. There is good amount of bone formed. Now, anytime if it fails, I can go ahead with an immediate extraction and implant placement. So I would say these are pre-implant strategies. Now we'll go on to the See here, you don't see much of theoretical side. Usually, people think MTA is something which can be used only on the anterior teeth. Fine. So here is a case wherein I have used it on first molar for a very young boy. So there is a big periapical lesion on the mesial aspect. I guess you all can see the lesion. Suraj, in case of a problem, you can always report it to me. I guess I am audible to everybody. I guess
Sure, doctor.
everything is going on fine.
All well.
Suraj, are you here? All fine? Shall I go ahead?
Sure, doctor. Please.
Fine. So I am having a big lesion in this case on the mesial, and the apex is not well formed. Fine, I've marked the lesion. You can see the lesion, and this is the radiograph wherein I've placed a plugger to almost see. We always try to keep it 2 mm short of the working line, and let me tell you, it's like errors are always common. Here, I have taken it almost to 1 mm short of the apex. So I won't say it's an error. It happens to all of us. Fine. But I mean, it's like it's within the canal space. And that is why we say exposing a radiograph after placing the plugger is very important. Now, what I can do is I can still take it back 1 mm, mark the point on the plugger, and when I place the MTA, I can calibrate it to the mark which I've made after retracting the plugger. So this is after packing MTA in all the canals. The mesiobuccal, mesiolingual, the distals, all are packed completely. There's no gada perca gone in this case. It's all empty. So that's a follow-up of this case, 3-month follow-up. You can see all the radiolucency is gone. It's all taken up nicely. This radiograph was taken on 2017, February 5th. And this is the present status. If you see, you can see the second molar was just rudimentary when I started with the treatment. In the 3-month follow-up, you can see it is still developing. And now you can see it's almost going towards the apical development. And now, when I see the 6, that's not the thing we are focusing on. Now, when I see the 6, I can see there is good amount of cementum formation. The root formation is completed. If you go back, I've filled it at the apex. Now, after 3 years, when I evaluate this case, I can see there is good root end formation. All the root ends are closed. So, what does this signify? MT is such we call bioactive. MT is such a bioactive material. Maybe mainly due to its high pH and maybe due to the findings that it helps to produce, it helps formation of blasts, and maybe due to the finding, maybe due to the clinical due to the research findings that most of the time the cementoblast can attach to the MTA. So here I can see that there is regeneration of the cementoblast. All the root end is being formed, and all the lesion is resolved now. We had such a big lesion, everything is resolved. The tooth is well in function. The canal space inside is closed with something which is offering almost 70 megapascals of shear strength. So we have a system which is much more stable than a root canal treated tooth. That is one reason I feel the entire root with MTA. Of course, this is one of the most expensive restorations because this can consume about almost one vial, that is 0.14 grams of MT. Now let's see a super interesting case. This was a referred case. I don't know how to call this case. Huh? So initially, when I saw the IUPA, I suspected a dense invaginatus, but it can be root dilaceration too. To differentiate between the two, at this point of time, I need a good this thing. What do you call it? CBCT. But being a referred case, it's like the patient was coming from a far off place. To me, management is important, not finding is it root dilaceration or is it a dense invaginatus. Whatever it be, if I manage it, things are going to be fine. So this is the initial clinical picture. You can see the tooth is much more buccally placed. There is a periapical abscess, and this is the radiographic finding. And this is what made the dentist to refer this case. He's a friend of mine to refer this case to me. Again, a very astonishing clinical picture. Wherever you put the vial, you have a canal. So you would see a lot of scouting videos. You would see a lot of scouting high going nowadays. But after placing all my files, I was at a fix. Now, how would I proceed? 4 files was going inside. When I was seeing from my microscope, I was not getting a very clear idea of how the canal systems are. Fine. I have a lesion here. So now, what I did is, I tried packing MT at the apical region. Then after a 1 month follow-up, I started seeing that almost the lesion is healing. All these acute angles over here. Maybe that is why I call this can be a case between halfway between an invaginatus and halfway between root dilaceration. So all these bump over here was removed and I gave a composite restoration. There was a lesion, you can see there was a lesion. And after the root canal treatment, after 3 months, when I'm seeing the case, I'm seeing the lesion is healing. Fine. Now, there comes a very big question. How do, see, I have a large number of crowd asking me, how did I place MTA here? in such an intricate canal system. The only answer, and if you see, you can see that the region between both these major canals is an isthmus, and you can see the obturation material in between two. So these are games of dedication. I'm not saying I'm a dedicated dentist, but I enjoy what I do. I really enjoy dentistry, and that is the main reason which forced me to do all these cases, and something which helps to maintain the natural tooth. Maybe later, when this boy, he's a very young boy, maybe 8 or 9 years of age. Maybe after, I mean, 10 years, I might have to extract this and give an implant, but I don't mind. I would be having good amount of bone support circumferentially to place an implant at that time. So these, again, comes under the classification pre-implant treatments. So I placed an apical plug of MTA of almost 4 millimeter, and the rest is backfill. As you have seen in the video, just backfill it with the backfill gun. So that's it. This is how we came to me. So I was showing you, I removed this bump, gave a composite filling. You can see here. Now we can see all the abscess, everything is healed up nicely. When he reported me, to me, the tooth is mobile. Now the tooth is very firm. You can see good amount of keratinized tissue everywhere. And finally, I went ahead creating a very nice composite. This is almost like a crown. It's injection molded. That is again another terminology. I don't know how much people will understand about this. It's an injection molded restoration wherein I've kept two bioclear matrices and then injection molded heated composite circumferentially after micro etching the two, and then it was cut back, finished and polished. So maybe those things that's altogether a different topic. So let's not go into the aesthetic concerns of this. So this is after a week or so. You can see the gingiva is nicely healed. I had an abscess here, which is all fine. You can see good amount of bone support here, nice emergence profile, and I could gift this boy with a tooth which is almost looking very natural. And that's the final clinical picture. That's the radiographic image. This is the comparison between the preoperative and the postoperative. So what I would say is not only the endodontic part is important. Fine, how much ever good endodontics you do it with MTA, you do it with gold, you do it with whatever. What the patient is going to appreciate is when you reconstruct the coronal structure also equally effective, and that too in a very aesthetic manner. Now I can see that the endo part is nicely done. You can see here. This is what it was before. The endo is nicely done. This was the coronal structure. So I could almost take it to this level. Now you can see the gingival zeniths are almost matching. Have a very good emergence profile, and you can see a good amount of keratinized tissue covering the entire tooth, making this less susceptible to all sorts of periodontal insults. All these things are very important. So let's not talk from just endodontic point of view. Restorative point of view is also very important. Again, see, when we talk of a material, when we talk of a subject, It is equally important. These are cases which I've done in the long past. I would tell you why. I would explain certain things after this. These cases are done almost, almost 5, 6 years back. So I have a badly mutilated canine here. So that's it after isolation. And let me tell you, all these are clicked with mobile phones. I was not into photography during those times, and no longer I do this type of treatment also. But this is to explain some advantages of MT. So, while on excavation, there was an exposure of the pulp. So you can see disinfection with the first step is disinfection. Then MTA was placed, direct pulp capping with MTA, and that's the final restoration. This might not be up to the liking of everybody. I can see all these two have little bit of decalcifications, everything. So I have restored the distal half of the tooth in harmony with the decalcified dentition which is present on the patient's mouth. All these are effects created so as to give a natural effect. Anyway, after 6 or 7 years also, these things are surviving, and I've done many other treatments for these people. Still, they're not much focused. In fact, for this lady, it's like these restorations are not existing now. I've done a full mouth rehabilitation for this lady, and now it's all. I'm not done root canal on this. These are all replaced with veneers and crowns now. And this is how you build up cases. So she came to me for just a restoration with a badly mutilated. She was told by somebody that this has to undergo root canal treatment. We avoided a root canal treatment, and that paved the way towards a full mouth rehabilitation, which I could do on her. So almost all the 28 teeth are now involved with either veneers, crowns, some sort of restoration. So again, that is how we build up things. So that is not the thing which I want to highlight in this. Even in direct exposures, we can do direct pulp capping. Here I've done. It's like whenever I expose, and if I have to go ahead with a restoration, I prefer a bit of disinfection with chlorhexidine, and then I go ahead with restoring the tooth. Now we have a very interesting case. So most of the time I see open apex. Sometimes it is existing, sometimes it is created by us. So this is a very interesting case wherein this was treated by at a big place by an endodontist itself. Uh, and then the patient happened to be the son of a dentist itself. Then they developed a great amount of pain. They went to another endodontist. Then it's like they developed an opinion with the first endodontist, with the second endodontist, that the GP might be floating in the sinus when they try to retrieve it. Then this case was referred to me. So I just removed the tooth, and you can see the huge amount of GP which is over extruding. I removed all of it, re-implanted the tooth, The GP was removed from the canal, calcium hydroxide was placed. So before obturating any case, it is very important that the existing inflammatory condition should be stopped. So I placed calcium hydroxide inside, re-implanted the tooth. Then I recall this case after 3 weeks. You can see the plugger fit. I had two canals here, the buccal canal system and the palatal canal system. You can see the plugger fit in the buccal canal system here. You can see the plugger fit in the palatal canal system here. MTA was placed. There is good amount of apical closure with MTA. Later backfilled, and the game was finished. And this is almost 5 years after this. I've given a vertebrate crown also with this. So I'm not going into the prosthetic rehabilitation side because that is altogether a different thing. When I say vertebrate crowns, it becomes a very different thing, entity, because I mean those things cannot be explained in a very limited time format like this. So now we'll see a very interesting case. This patient had a tooth which was root canal treatment, treated a few years back. There was two instruments that got fractured at the apical third. She had an episectomy done here in India when she developed symptoms after the apical, after the root canal treatment. Then she went abroad and she was, because she was working there. Again, after a few years, she developed a pain. So she went to a dentist over there, and we have seen that these foreigners have a very habit of looking too down on us. So the dentist scared her, saying that you have two instruments inside, and that is why you have a great amount of pain. Then a friend of mine referred her to our place. So this is the initial finding. I can see two instruments inside. So my aim is not to retrieve, but to retract. But to bypass. Bypassed it, but see, due to the motivation of her New Zealand dentist, there was but no other option but to retrieve. The patient wanted them to be retrieved. She, being a nurse, it's sometimes astonishing to remember all these things. Even when I do a webinar, it feels amazing to discuss all these things with you. See, under LA, under rubber dam, I'm performing such a procedure. And the moment I retrieved both the instrument, the patient was still, I fine, how I'm so much relieved now, I don't feel any pain. Huh? So it's like a total laughing situation for us because we know nothing has happened. She's under local anesthesia, and it is just a psychological thing that when the instruments are relieved, the patient is happy. So both the instruments were retrieved. Yeah, we can see both the instruments were retrieved. Calcium hydroxide dressing was given because there was a bit of ooze, and we don't want to obturate a case when it is infected. I don't believe in that. And later, 1 week later, the patient was called. The calcium hydroxide dressing was removed. Then an apical plug of MTA was given, and the rest was backfilled. The entrance was filled with composite resin, and the restoration was completed. And you can see the CBCT. And if you see the CBCT, you can see there is a great amount of apical resorption, almost like an open apex case. And you can see the direction into which both the instruments was gone. One instrument is in this segment. It might have gone in this direction, trying to bypass. It went into the buccal side and might have ended up in a perforation there. But now everything is well managed with MTA. And that is why I say this is a wonderful material. Because these are cases which I have done in the long past. If you see my Facebook page, you can see that these cases are done. These are actually, I have posted these cases on my FB page. It is done almost 4 5 years back, and still these people remains happy. And these are the basic elements of my success. They refer a lot of patients to me. And that is how we improve our practice. Let's let's come on to yet another very interesting case. So here, uh, see, yet another referred case. She had severe pain with the lower left second molar. A root canal treatment was done, a post was given, a crown was given, and then she developed a post treatment disease, as you see on the radiograph here. So the first thing is the coronal disassembly. All the crown, everything was taken out. The post was taken out with ultrasonics. And then we went ahead with an obturation with MTA. You can see the follow-up. The lesion is healing. Then we gave a crown, no post, nothing. A verteprep crown was given, and the lesion is nicely healing. You can see the pre-op and post-op. It's always a happiness when you see the lesion healing, because it's a marker towards our success. Now, one thing I want to ask you is, do we use MTA only for cases with open apex? Not at all. This is yet another young girl, maybe in her 15 years or 16 years. There was great amount of pain on the second molar, paresthesia on the second molar. A deep filling was done some time back. She developed paresthesia of her lower lip. So that's a very tricky situation. We don't know what is going to happen when we are going to manage such a case. So I cleaned it well, irrigated well. Again, I did want to keep this case because to err is to him. Sometimes we do mistakes. I wanted to keep my calcium hydroxide all within the canal, but you can see it extruded. I was lucky that didn't go too much into the canal. A bit might be. But after 3 years, after 3 months, all the numbness, paresthesia, everything has subsided. You can see the plug of it. I obturated with MTA, and this is a 3-month follow-up. All the calcium hydroxide has been resorbed. The lesion has nicely healed. So that is what this wonder material does. Once you learn to play with this material, it opens too much of opportunities to save a natural tooth. See another case. See, sometimes as I said before, sometimes we have open apices, sometimes we have created open apices. Here, a root canal treatment with a periapical surgery was done. Vasectomy was done. And I have seen this thing. Even during my graduation days, I have seen that most of the time the flap is open, the root end is cut, the extruding gadaparcha is cold burnished. Not the term, it's cold burnished. And there is no root end preparation, there is no retrograde filling, nothing. So that might be something what has happened to this case also. So this is what eventually it is. Even the episectomy is not done with a sharp, clear, nice cut. It is too rugged. Fine. All the existing GP was removed. Now I had too much of jumping of my apex locator reading in this area, which shows that it is too rugged. There are multiple communications with the periodontium at these regions. So I would prefer to keep my obturation preferably at this level, beyond which you don't know where the tooth is, where the periodontium is, because it's obliquely sliced off. So again, MTA was packed in. And this is a great case. I've obturated this. You can see an impacted canine here, retained deciduous. I've removed this retained deciduous, pulled this down, then it was splintered at the same level. And later, all these things have been replaced with good crowns and all those things now. But again, since it doesn't come in the confinedness of our today's discussion, I'm not including the restorative pictures. But it's nice to see because, I mean, you know why? This is an impacted canine. Getting it out, it is intentionally, I mean, extracting it, intentionally re-implanting it, then this thing taking up, then you're doing a smile design. All these things gives us great amount of happiness because we mean, see, we have been told these things are too risky and they come with a lot of failure rate. I differ. I say, I'll go ahead, we'll try to manage, talk to the patient. If he's willing, go ahead, do it. And when you do it with total dedication, success is always yours. So, is MTA used only in the apical aspect? No. This is one referred case by a periodontist. There is a root resorption on the middle third. So I got this case in this form. All the canals were prepared. Calcium hydroxide was placed inside, and you can see the calcium hydroxide exiting out through the resorption found on the middle third. A very young boy. So how to manage this case? Let's see. So all the calcium hydroxide was flushed off. Then I started packing MT. All this area was packed with MTA. And you can see now MTA coming out through the communication. Opened the flap. The extruding MTA was nicely removed. And I could nicely seal the communicating areas with MTA through the opened flap. And then the flap was sutured. And finally, I gave this is a temporary, I mean, you can call it provisional restoration. This is a milled acrylic crown. So that was given, and then the case was referred back to the referee. And you can see even the gingiva, everything is nicely formed. So that is why I said MTA is a material which helps you to manage wide arena of cases wherein we mostly think it is too difficult to retain or treat a natural tooth. Here I can see after 3 months, I can see good bone formation on the lateral aspect where the communication was there. The communication is nicely sealed and the tooth is well inserted. So with this, we are almost winding up. See, let me tell you one thing. The MTA, which I mostly use, even for me, even when it is irrigant, it has to come from Serecomed. I trust the company a lot. The Serecomed irrigants are really good. I would show you 101 cases with lateral canals opened, with isthmus opened, everything which happened. Their products, I mean, the Serecomed products are mind blowing. So I mostly use the MTA Plus as well as the Bio MTA. You can contact Medesta for their purchases. If you intend to purchase, you can call up Suraj. You can call up Medesta anytime. They would support you all to. All through your journey in your restorative as well as the endodontic phase. So that's it. So you can see here, this is my team. Teamwork is very important for all successful outcomes. Another thing which I want to tell you is we are going ahead through a very bad time. I would myself tell everybody to restrict your practices, do elective procedures. Whenever you do an operatory procedure, always make sure you put a rubber dam, which is very important. I would tell it's high time to shift to electric handpieces because they produce very less aerosols. So these are some ways wherein we can keep ourselves safe during this pandemic times. Let me check the questions. Yeah. So with this, we end up today's session. Uh, Thank you for the participation. Don't go away. I'll be answering the questions which you have raised. So this is my number. You can anytime. You can see. I have a I have a very bad reputation for picking up the calls. Most of the time, I don't pick up the calls. You can always text me. I would be always texting you back with any doubt. You can always WhatsApp me in this number. You will always get a response. So let me go through the questions. So one is how much do you charge for an MTA obturation? That has been asked by I don't know the name. Uh, See, let me tell you, there is no dentistry which exists without charging. We have to adequately charge. Fine. So my way is, if I'm using MT, let me be very frank with you. I do treatments for two types of people: for those who need the treatment and those who want the treatment. Fine. Somebody who is in great pain, somebody who is in great distress. Fine. I don't mind. I would just go ahead with the treatment and I don't mind about the charges. And it is different for a person who comes to me with a white spot lesion on an anterior tooth. Why? Looking into her mouth, I see that all her four anteriors or his or her four posteriors molars are in great requirement for a root canal treatment, badly mutilated, but the patient is not at all bothered about all those things. They just want the anterior correction. So those are the treatment people whom I charge. Fine. So you should be charging for those who want the treatment. For those who need the treatment, forget the charges, do your job, and be happy. Then Vinay Vasudevan has asked me, isn't moisture required to set MTA? Of course, moisture is required to set MTA. And in most of the cases, what do we find is the moisture which the MTA gains from the periapical region is well enough for its final set. So even if you're obturating on the same visit, it doesn't matter much. Even you can see, we can find journals also favoring this. Then Dr. Rajan has asked me, please to mention the irrigation protocol. A very good question. See, irrigation protocol for an open apex case, it is basically 0.5 to 1% of sodium hypochlorite. The percentage, the concentration of hypochlorite is very less. And how you overcome that is by more irrigants and more time spent for irrigants, because shaping has no much role. It is just cleaning which has got its greater role. So irrigate profusely, use less concentration hypochlorite, irrigate for a longer period of time, irrigate with more volume of irrigant. So I guess irrigation solution and protocol, all these things. I mean, one more question was there on the topic, which I have said, 0.5 to 1%. Then how to remove the GP in over-obturated case? Either you can try it through your intracanal access. You can try to retrieve the GP. Most of the time it happens, sometimes it doesn't. The case where, in which I presented over here, the tooth was intentionally extracted and the GP was removed. Then I have a question. Pulpal exposure of clinical third fracture of a crown by MTA, will it help apexogenesis? The question is not clear, but let me tell you one thing. It is like, seems pulpotomy, then MTA, and will it help the regeneration of the apex? Will it help apexogenesis, not apexification? If at all we are removing partial pulp and then placing MTA inside, see, I've done a lot of all these things. Revascularization, pulpotomy with MT, all these things, it is like if my luck is good and patient's luck is really good, things are going to work. And you don't know when things go wrong, when my luck is bad, and I don't know when my patient's luck is bad. So under such circumstances, all these things are going to, they don't work. So first thing I would ask my patient is, you want a sure shot thing, or are you ready to take a chance? If my patient is ready to take a chance, I can go ahead with revascularization, I can go ahead with pulpotomy, all these things are fine. But what I've seen is 20 to 30% of the times you have success, and 70 to 80% times you have failures. So I would prefer, when I explain the patient also, I would say that if I'm closing the apical third with MTA, I would say that this is going to stay longer, rather than doing something in between all these things. Then there is one more question. What about irrigating beyond the apex with chlorhexidine? Fine, you go ahead, irrigate beyond the apex with chlorhexidine. That is the only thing which you can irrigate beyond the apex. Post irrigation is permissible with chlorhexidine, no problem. And another question is, you use white or gray? Always white. I don't prefer gray. I prefer white MT. Then Dr. Akhilesh has asked me till what length would the irrigation needle be placed? So I would tell you, I would always use a side vented needle. I would place it 1 mm short of my working length, and I would irrigate with 0.5 to 1% hypochlorite. Fine. Never use a normal needle which opens at the apex in an open apex case. Always use side vented needles in an open apex case. So, Suraj, are you hearing me? These are the questions. Things. How was it? It's
Yes,
like
doctor.
everything fine. Are
I
there
think the
any more
questions are
questions?
finished. Yeah, the questions are all answered.
Yeah. So thank you very much for the patient listening. Be very, frank on asking queries about all these topics. You can contact me on my WhatsApp number, and you can contact Suraj for the purchases. All these things are absolutely fine. So thank you very much for joining. We'll again meet with some other very good topic later. So thank you all. We'll meet again. Thank you.
Thank you, doctor. It was a very lovely session. And all participants wishing a very great Sunday evening.
Thank you, Suraj. Thank you. Thank you very much because, as I said, this is the 8th or the 9th session we have been doing together, and thank you for the constant support.
Thanks for your support too, doctor.
Thank you. Thank you very much.
So that's the end of the
So we
program. Thank
will
you all
wind up.
participants. Yeah.
Yeah.